Hello, everyone. Welcome to Study Medicine Europe Symposium about Acute Kidney Injury with Dr. Kajenthiny Ganeshamoorthy. We're so glad all of you could join us today, and we look forward to sharing this very interesting material with you. Just a quick introduction for those of you who are attending one of our symposiums for the first time. These periodic symposiums are dedicated to presenting relevant information and trainings related to the medical, dental, and veterinary fields. These free webinars are open to all SME students as one of the many services we provide throughout your academic career. They are great opportunities to learn and ask questions of professionals in your field of study. We also provide a certificate of attendance for each symposium, so you can include these types of additional trainings on your resume. We'll provide you with a QR code at the end of the symposium so you can complete a feedback form and receive your certificate of participation. So here's a look at the agenda for today's symposium. We've given everyone some time to join. So shortly here, we're going to turn the spotlight over to our guest, Dr. Ganeshamoorthy, for her presentation. After her presentation, we'll have about 10 to 15 minutes for Q&A. The way that we're going to run the Q&A, and I'll remind you when we get further to that point, because this is recorded and we need to protect everyone's personal information, you will be requested to utilize the Q&A feature. It's a chat here inside the webinar. So you can anonymously post your questions, and then Dr. Ganeshamoorthy will read them off without using your names or personal info and answer them in turn. So, all right, now that we've given everyone some time to join, we are going to turn it over to Dr. Ganeshamoorthy.
Thank you so much for inviting me to speak on a topic of my choice, and thank you everyone for attending the symposium. Before we talk about AKI or acute kidney injury, I'll just say a little brief summary of myself and where I am along the training program. So my name is Kaj, and I'm a clinical fellow FY2, currently working in oncology at the Aberdeen Royal Infirmary in Scotland. I actually studied in Iași, Gregor T. Popper, University of Medicine and Pharmacy in Romania, and graduated in 2020. Then went on to do a 2-year clinical fellow program, mimicking the foundation program as an FY1 initially, and now as an FY2 in ARI. So that's my spiel over and done with. So when SME kindly asked me to speak about a topic, I really thought about, first of all, what would be interesting to talk about, and also what would be useful as current medical students who are almost finishing up the degree, and also prospective junior doctors. What's something that individuals come across day to day, regardless of what specialty they work in. And one of the presentations that I've often come across in all my various rotations so far is acute kidney injury, or AKI. So let's see what AKI stands for and what it defines. Right, so essentially the kidneys, when they're functioning, they're great, very much a needed organ, as is with all organs, but as resilient as they are, their function can drastically drop, and it's this very quick, sudden drop in kidney function that is defined as an acute kidney injury. So that's changes that occur within or up to the last 7 days, where the kidney is not able to maintain its homeostasis, and this just builds up on all the waste material that the kidneys are normally in charge of removing, and of those, it's predominantly the nitrogen waste. So if we were to look at values and how to identify AKI on blood work, that is using the 2 factors, which is creatinine and eGFR. Predominantly with the creatinine, it is 1.5 to 2 times the baseline of what your patient's normal creatinine levels are. So if, for example, their baseline is 90, you can say that, oh, my math, 135, a creatinine of 135 and above, especially if you can have blood work within a week of each other, and there's an increase, indicates that there is an AKI. Whether that's a severe AKI or not, we will come across in a couple of slides, but this is predominantly how you identify if someone's developed an AKI. Now, of course, while blood works are in progress and being reported on, there are other indicators, and of which the biggest indicator is urine output, or in our case, the lack of urine output. Off the top of my head, normally patients are not able to accurately give volume of urine output. So you would ask, how often do you normally pass urine? And if so, has there been a reduction in frequency of urine or volume of urine? For quantitative purposes, we would say those who have got a urine output of less than 300 mils in the last 12 hours would indicate an AKI, although that should be further investigated with blood work. Another definition of that is oliguria, which is when you have less than 300 milliliters of urine output in a 24-hour period, or if they're anuric, which means they've had no urine output in the last 24 hours, that's also a key sign. If we look at the different causes of AKI, and we think of the kidneys as the middle point, we need to think about, well, what causes can be related to things before they reach the kidney. So they're predominantly termed as pre-renal causes, or what causes can be due to changes in the kidney itself. So that's defined as intrinsic causes. Now, even within the renal system, you've got the glomerular part of the renal system, and then you've got the tubulointerstitial part. And so you can have different causes affecting different parts of the renal tract, and therefore need to be treated differently, but still can lead to an AKI. And then, of course, you have factors past the point of the kidneys. So that could be the bladder, urethra, and prostate. That can be the primary issue, primary change in health, and that can have a backlog and cause an AKI. So we'll look at those individually and see what factors come under these different causes. So if we look at pre-renal causes, we're looking at any issues that crop up before they even reach the kidneys. And we know that with the kidneys, it's the blood flow that enters the kidneys, and the kidneys filter out waste material. So if we think about the blood flow entering the kidneys, or in our case, normally the lack of blood flow, that in itself is a big indicator of what types of causes there are for pre-renal causes. And so we have things like the absolute hypervolemia. So any blood loss, any pardon me, any decrease in oral fluid intake. So all of that is essentially absolute hypervolemia. This is overall decrease in body volume, and that can in itself cause a slower flow rate into the kidneys, and therefore your kidneys aren't able to filter out the same at the same rate it should be doing, and therefore any poor perfusion of the kidney can lead to an AKI. Now, another cause is a relative hypervolemia. So it could be that the total volume of the body in itself isn't affected or changed, but the volume reaching the kidneys can be reduced. So a drop in blood pressure and similar presentations can lead to less blood flow reaching the kidneys itself, and therefore you have relative hypervolemia. And essentially the organ that does control and also pump out blood, of course, is the heart. And so if you've got reduced cardiac output, that in itself will mean reduced blood flow to the kidneys. So a heart failure picture can very easily lead to reduced perfusion of the kidneys, and that can have a knock-on effect and create an AKI. And also, if we think about the vessels themselves, the renal vein and renal artery, so specifically the renal artery and the vasculature that provides blood supply through the renal artery into the kidneys. If there is an occlusion in that, whether that be a clot, a mass malignancy pushing on the artery, or if there is a bleed from that vessel, then that can also mean decreased blood flow entering the kidneys. So overall, these are some of the most common causes of pre-renal AKI. And essentially the first port of management for this is to first do a very good volume status check. So and look at input and output charting, and make sure that you are providing sufficient volume of fluid with a good fluid review, whether it be needing a few boluses of fluid to bring up the blood pressure, whether it being if the patient has come in with a dehydrated picture, in which case you would not give just volume for maintenance, but also reperfusion. And so you would give faster volume of fluid, and that can bring up both the blood pressure and also the volume of blood perfusing the kidneys. And hopefully that will see good changes in or improvement in the AKI. And now we'll move on to the intrinsic causes. So this is essentially the kidney themselves, and also anything that can act on the kidneys to reduce the efficiency of the kidney. So this is, for example, necrosis of the tubular vasculature of the kidneys, but most specifically an acute necrosis. So ischemia, so cell death, tissue death. So if blood flow to the kidney tissue themselves is reduced, and the renal tissue becomes ischemic, then that can also mean the volume cannot be filtered through the kidneys efficiently. More commonly, we need to look at toxins. So the toxins can be either toxins produced by the body itself, so blood itself, so hemoglobin or myoglobin, but also us doctors and healthcare professionals who give patients different medications that maybe are effective for the reason of, for example, maintaining blood pressure or blood pressure control or treating an infection. But along with the benefits of certain medication, there also comes with it risks and side effects. And often the side effects can be a decrease in renal function. Some common medications are antibiotics. One of my favorites to look out for is gentamicin, which is a great antibiotic. We often use it for things like abdominal sepsis. It's only one dose, and often you have up to about 3, maybe 4 doses, and normally the infection starts clearing up quite quickly, and you see the infection markers coming down. But unfortunately, it's also very toxic towards the kidneys. Now, if we were to think of more common medication that you would find patients on long-term and can also affect the kidneys are things like your diuretics, so furosemide and spironolactones. They're great to get rid of the excess water buildup in the body, but they also are tough on the kidneys. You also have your ACE inhibitors, so your ramiprils and lisonoprils. Again, they're great for blood pressure control, but not so great for the kidneys. And then you have your type 2 diabetic patients who are often on things like metformin or aminoglycosides. And again, they might have been on these for a fair while, but if they have had a acute infection recently, or they've had other agents such as a radiocontrast used for a CT scan recently, the combination of their long-term medications, such as the ones I've mentioned, along with a more acute change in the in recent times, can kick off and cause an AKI to develop. And of course, you have things like NSAIDs and heavy metals and poisons that are very vulnerable for the kidneys. Then you have inflammation of both the glomerular tissue and also the tubular tissue. And that can also mean filtration is not taking place efficiently, and the flow through the kidneys are not efficient, leading to an AKI. So for this, it's very much first of all, stopping any factors that are triggering or aggravating the kidneys. So whether that be the long-term ACE inhibitors, diuretics, making sure no further radiocontrasts are used for CTs, and just removing the causes, removing anything that is entering the body that can be vulnerable for the kidneys. That's the first step, and also making sure you have a good management of the different blood work, especially the full blood count, and also looking at autoimmune screens, and dipping the urine for any proteins, any nitrates, and if so, acting on them accordingly. And moving on to post-renal factors. So these are in males, prostatic hypertrophy or even a prostatic cancer. That's often blocking the urinary outflow. And so you get a buildup in both the bladder and also backlogged into the kidneys. So the kidneys are not able to function as efficiently as they should. Now, if you have a patient who has a long-term catheter or even had a catheter put in recently, and you look at the input-output chart and you notice that the urine output is has decreased, then that is an indication of a blocked catheter. Of course, alternatively, if you look at the catheter itself and look at if there's any clots seen in the catheter tube coming out, if the catheter bag is quite cloudy, then those are all suggestive of a catheter block. And so that can be easily resolved with either flushing the catheter, or if you're suspecting an infection, then completely changing the catheter. And of course, another cause of post-renal AKI is malignancy. So that can be malignancies of the kidney itself, but also malignancies of the bladder and the prostate. And so some simple management techniques, including doing a bladder scan to make sure that there's no urinary retention. If the patient doesn't have a catheter in already and you do find a urinary retention, and urinary retention is defined as 500 mils found in the bladder through an ultrasound scan, then popping a catheter in and seeing if that does relieve and give you a good urine output is a simple treatment plan. Again, as I mentioned, flushing the catheter and even imaging the kidneys and also the renal tract using an ultrasound are all key steps to take. So moving on, looking at the stages. So as I mentioned earlier, first of all, it's important to identify that a patient has AKI, but it's also quite important to understand or identify how severe the AKI is. Now, treatment will not change much whether the AKI is stage 1 or stage 3, but their prognosis and also an idea of how long the treatment is needed will be led by how severe the AKI is. So as mentioned before, a creatinine level of 1.5 to 2 times their baseline is an AKI, and it's specifically stage 1. Now, if we're to look at stage 2, that's between 2 to 3 times their baseline. And if we were to look at stage 3, then it's 3 times or more. So it's very easy to remember in terms of what value you have to multiply the creatinine by to understand if the patient in front of you has a severe AKI of, let's say, 3, or if they have a mild AKI of 1. But regardless, starting them on quick management is the key. So moving on. So of course, patients don't conveniently come with their diagnosis in hand. The closest I've gotten to that conveniency was when I did acute medicine in my last block, where thankfully GPs screened patients and also came up with their own impressions. So it did give me a little leeway to kind of guide where I should investigate for the patients coming in. And if for example the GP had already identified on the blood work that the patient has an AKI, then it was very convenient. But that's not always the case. So when a patient presents, they may be presenting with things like a weight loss or decreased urine output or suprapubic pain. These are all some typical presentations of an AKI, but also of other causes that can lead to an AKI. But things that you specifically need to look out for is on blood work is hyperkalemia. So that in itself is an emergency that does need to be treated. We identify hyperkalemia as potassium levels of more than 5.8. In some trusts, I believe that can be a minimum of 6, but in the trust I'm working in, it's normally between 5.5 and 5.8. So you need to treat the hyperkalemia. If, for example, the patient has got nausea and vomiting, you can link that to one of the causes of an AKI, which is volume depletion. Of course, when a patient is vomiting, they're less likely to take insufficient fluids, and therefore their overall volume is depleted, and so you would give them fluids. Another identifying sign is pulmonary edema. So on chest X-ray, if you find the lungs to be fluid filled, then you can see that the perfusion and circulation is not so efficient, and so you will need to treat the AKI, but you'll also need to treat the pulmonary edema by ensuring that the lungs don't build up on the fluid. Again, weight gain could be quite acute as well. So specifically in the lower limbs and, peripheral edema. So those are things that you need to look out for. And so to treat it, you may even need the diuretics, but again, that has to be closely balanced with the AKI, which will worsen on giving diuretics. So it might be that you would need to give some slow fluids initially to reperfuse the kidneys, and then with, of course, the help of a senior medical team and their advice, then give diuretics to bring down the peripheral edema. And of course, hypertension itself can also cause issues with the renal perfusion. And so making sure the blood pressure is well controlled will have a longer lasting and improve the overall effect on the kidneys, as well as with ascites, so identifying ascites, and also the pressure, the fluid buildup in the abdomen can also affect flow into the kidneys and build up on the pressure applied on the vessels, and therefore relieving the ascites through an ascitic tap can also improve kidney function. Another sign is the flapping hands and also encephalopathy, and you will need to identify the underlying cause for that, and that will also help with the AKI. So often it's not just treating the AKI itself, but you would have to be treating underlying causes simultaneously so that the AKI does not persist or reoccur. Okay, so I spoke earlier about fluid reviews and making sure a patient is well perfused. So doing an accurate fluid review, identifying if they are hypervolemic, euvolemic, or hypervolemic is very important. Often you are presented with hypovolemia because the AKI develops due to nausea and vomiting, diarrhea, reduced oral intake. I speak more about my recent patients in oncology who often have these symptoms due to their chemotherapy, radiotherapy, or immunotherapy. And so making sure that their fluid intake and the fluid status is maintained through boluses to initially rehydrate the patient. And then once they are rehydrated, to maintain that hydration with maintenance fluid. So maintenance fluid is very much weight dependent, and also changes to it depending on if they need potassium or not, or if they're at risk of having low sodium, also determines what fluid is used. But normally it can be something like between 50 mils an hour and 100 mils an hour, depending on their weight. And in the rare cases that you find the patient to be fluid overloaded with oliguria or anuria, then this definitely needs a senior renal review. Often it might be that they are in need of dialysis or other more acute management, which is beyond a junior doctor's capabilities. So that's something that should be escalated earlier rather than later. Now, if we talk about treatment, as I said, identifying underlying causes and treating them. So things like with hyperkalemia, making sure you give insulin dextrose and make sure an ECG is done to ensure there's no ECG changes. If they are poorly responding to insulin dextrose, our particular trust uses Localma, which is a binder, and there might be other alternatives. As I mentioned earlier on, removing the offending cause. So whether it be withholding the diuretic, withholding the ACE inhibitor, withholding the metformin, all of that can and will see improvement in the renal function. In the case of fluid overload and poorly controlled hyperkalemia, that can also lead to needing dialysis. And again, that is determined by a registrar or a consultant. And often the case, even if you're not in a renal setting, giving them a good, thorough history of the presenting patient will aid in their clinical decision making and how quickly the patient is able to obtain dialysis if needed. Now, if, for example, you are giving medication that is still very much needed, but is also affecting your kidneys, such as the gentamicin I mentioned earlier for an abdominal infection, the renal handbook is a very handy tool to use, and that often has either dose adjustments to ensure kidney function is maintained and improved, but at the same time, treatment can be given, or alternatives. So for the specific example of gentamicin, the trust I work in uses the alternative of aztreonam and dose adjusting aztreonam depending on the EGFR values. And in certain cases where you are fluid overloaded, unlike in hypervolemia, you would have to pop patients onto fluid restrictions. So specifically, I've come across this in patients with heart failure and patients on dialysis where they have fluid restrictions, and these can be as low as 750 mils in a 24-hour period, as well as restrictions on sodium and potassium intake, which is often managed by specialist dietitians. And you may also need to add in phosphate binders, depending on the phosphate levels. Right, so of course, all that I've spoken about, first of all, there's a fair bit of information there. And also, often the case is you would see a patient, you'd be clocking them in, let's say, half an hour at most, 45 minutes, where you're able to take history, do a quick clinical examination, and also start off simple investigations such as taking bloods, putting cannulas in ECGs, and urine dip and urine analysis, sending off a urine analysis. So things that you need to look out for if you're querying whether this patient has an AKI, and something that can be easily remembered is to shout. So don't actually shout, but think of the acronym SHOUT, which is think about a sepsis or an infection. Often that can cause a imbalance in your kidney function and kick off underlying causes such as long-term use of nephrotoxic drugs, and develop an AKI from that. So doing a septic screen, especially if you come across things like a fever or change in GCS, is always important. Next is hypovolemia, so a fluid review and starting on both a bolus of fluid as well as a strict fluid input-output charting will be very helpful, especially on managing the AKI going forward. And next, if you come across a patient, speaking of reduced urine output, always think about obstruction. And so a simple bladder scan and, of course, following that with a renal ultrasound request will give you a lot more information about what's going on. And of course, if you do find more than 500 mils of urine in the bladder, popping a catheter in is a quick resolution in the right direction. And next is a urine analysis. So with any AKI, it's very important to identify exactly what is being produced in the urine, whether the patient has an infection, so urosepsis, or if there's proteins in the urine, and what's happening with the glomerulus through this. That's very important. So it does give a lot of information, and it's a very simple test, bedside test to do. And next is to scan through the medications the patient's on and look for toxins that can be stopped or withheld. Okay, and in terms of another acronym to remember, if SHOUT is not something that comes to mind too easily, then a BUMP is another alternative, although one that I don't use as often. BUMP, so bloods, first of all, identifying the AKI through bloods. Sometimes in a rush of seeing multiple patients, you would send off the bloods but not have time to review in a timely manner. It pays in the long run to make sure that you do follow through the steps and review the bloods as and when they are reported, as it can aid in timely management and treatment. Next is an ultrasound, so things like hydronephrosis and masses can be picked up on ultrasound, and so requesting or performing an ultrasound of the renal tract is very important in the kidneys. And like I mentioned before, it's very important that even if, for example, you identify hypovolemia as like the underlying cause for this patient to be presenting with an AKI, often it's the case that it can be multifactorial, and so withholding nephrotoxic medication is key. It does not do them any harm to withhold for a few days whilst you let the kidneys bounce back. And also, of course, think about fluids, whether that be giving them fast fluids to rehydrate them, giving them maintenance fluids to support the kidneys, or in some cases, fluid restriction. So all this time, I've pretty much spoke of AKI, which is the acute kidney injury. And so typical presentations are you would see creatinine numbers of 100, 105 or more. But you do have patients who've got chronic kidney disease. And so if you're not familiar with the patient, you may look purely at the blood work, and especially if there aren't any blood test results consecutively in, let's say, the past few months, then it's very difficult to determine if the creatinine levels and the eGFR are new, acute, or if they're long-standing and this patient has chronic kidney disease. So let's look at the differences between the two. In terms of having a history of it, like I mentioned, acute kidney injury is something that takes place up to 7 days as a ballpark figure, whereas chronic kidney disease is a lot longer and is slow progressing. And so any of the symptoms that the patients will describe in an AKI will have come on in days to up to a week or two, whereas you would often see with CKD or chronic kidney disease, patients have got long-standing symptoms over months to years. Now, if we look at examination, the patient will present acutely unwell with derangements in their news. So that's either being hypotensive or fluid overloaded, or on their VBG having a metabolic acidosis. And they're all signs of new changes that take place. Whereas with a patient on CKD, they would have more longer-lasting effects on their examination. So that would be weight loss and a cachexic picture. So as is the case with patients suffering from cancers, but patients suffering from chronic kidney disease could also have a cachexic picture. You will also notice that their hemoglobin levels are generally low, and they would be anemic throughout. They would have skin changes that are longer lasting, so not really the pale skin tone that you would expect with an AKI picture, but more of a grey discoloration, more of a frail picture, and that is something you would notice in CKD. Also, and this is very much if you do have multiple blood work values across the past few months to year, in an AKI, you would see a rapid increase in the creatinine, and we've already talked about the numbers, whereas in chronic kidney disease, you would see a gradual increase with very little reversal in the creatinine. So you would not see, let's say, a drop from 200 back down to 100 in CKD. And the calcium levels in an AKI are normally low. They're not affected. Whereas with CKD, you will have low calcium levels, or alternatively, the patient will be on calcium replacement, such as calcitonin. And as mentioned previously, the hemoglobin will be normal or slightly lower in an AKI, whereas with a CKD, you will have what's called normocytic anemia. So your hemoglobin will be slightly low, but it won't be macrocytic or microcytic in nature. And if an ultrasound was done on a patient suffering from an AKI versus a patient suffering from CKD, often the ultrasounds in an AKI picture are normal, with the exception of an obstructive picture where you have hydronephrosis, and that can develop quite quickly. Whereas in a CKD patient, you will have scarring and asymmetry, different sizing of the kidneys possibly, and generally an enlargement as well, specifically with things like polycystic kidney disease or diabetes, and that will be seen in CKD. Right, so in summary, to stop an AKI, think about this stop, which is sepsis and sepsis screen, avoiding toxins, making sure you're optimizing blood pressure and volume status, and also preventing harm through treating the underlying cause, through withholding the toxic medication, and through doing good fluid reviews and fluid prescription. Thank you very much for listening to what has been slightly longer than I expected. But do you have any questions for me?
Thank you so much for your presentation. Just a quick reminder for you guys, a few of you have already started putting your anonymous questions in the Q&A. And some of them look really interesting. I'm excited to hear Dr. Ganeshamoorthy's responses to all of you. So yeah, go ahead and put your questions in the Q&A, and we'll go ahead and read them off and give you guys some answers.
Thank you very much. So someone has kindly asked me, how is one diagnosed with prerenal intrinsic or post-renal AKI? So how would you know where the patient lies on the scale? So often is the case as a junior doctor, you would not identify a prerenal intrinsic or post-renal cause straight away. The first thing and the most important thing is to identify the patient suffers from an AKI. Then through their history and also the examination, you would work through some of the most common causes for an AKI. So my personal favorite is looking at nephrotoxic medication, looking at if the patient has come in with an infective picture, looking at if the patient has got a good urine output, how their fluid status is. These are all information that once you gather and the picture just builds up, it's sometimes a process of elimination as well, that you would cut off less likely options and leave yourself with the most likely at the end. And it might be that you might be wrong. So often is the case, I've stopped nephrotoxic medication, and then I've also made sure to do a septic screen. The patient doesn't have an infective picture, the nephrotoxics are also not going through. Half a day later, and you make sure also that they've got sufficient fluid in them, and you look at their kidney function. If there's been no improvement, then you ask more questions. You go back to history taking, you go back to examination. You you think of further investigations such as an ultrasound. So sometimes I feel maybe an ultrasound is not needed initially, but if, for example, all the management that I've started off hasn't made any difference, then I will go back and revise and look at other options that, you know, should be used. Okay, another individuals asked, can too much alcohol intake cause AKI, and if yes, how? A very good question, and I'm going to put my hands up and say, off the top of my head, I am not sure. I am happy to go away and delve into this a wee bit and then come back to you on this. I think that there must be a portal or a way of giving this information and possibly popping it onto the box on YouTube or any other platform that this video will be put up on. But yeah, so that's another thing. As junior doctors, we do need to know what our limitations on knowledge is. If we don't know something, that doesn't mean that we're not good doctors. It just means that we don't know that piece of information. But we're also always learning new things. But yeah, so I'm going to put my hands up on that one. Also, someone else has kindly asked me, amongst the signs and symptoms you mentioned, like peripheral edema, nausea, hypertension, there are also pointers of chronic cardiac failure, which causes kidney problems, meaning the peripheral edema cannot be ruled out. So perfect, yeah. So as I mentioned, treating the underlying cause or managing the underlying cause, in this case, which is the cardiac failure, will also mean that the kidney function will improve. So essentially, there might be a few things that we would be making changes to, targeting specifically the kidneys, but the overall issue that we do need to manage more efficiently in a patient who presents with poorly managed cardiac failure leading to an AKI or even a CKD would be initially the cardiac failure. So yes, that is a very important point. Someone else has kindly asked me, can you please bring over the treatment of pulmonary edema by diuretics again? I understand diuretics can also cause AKI, so how do we manage that? Also, what is the significance of phosphate binders? What will lead to phosphate binding in the first place? Is osteoporosis common with AKI? Okay, so that's a handful. Let me start with diuretics. So often the case is first-line diuretics for both pulmonary edema and peripheral edema is things like furosemide, in some cases bumetanide or spironolactone. Now, of course, that does dry out the kidneys and can also cause an AKI. It's a bit like the chicken and the egg kind of scenario. And it also is an indication of poor prognosis when we're having to rehydrate the kidneys, but also be mindful and ensure that the lungs are not flooded or we're not having lots of fluid building up in the legs. There is no straightforward answer. It's generally led by the senior team as to which step to take first. Often is the case that I've seen myself. Patients are gently hydrated. We're talking very slow bag over 12, 15 hours, 50 mils an hour. And then if they're symptom controlled for their pulmonary edema, it might be that the kidney function does improve, and in which case they can be put on diuretics, IV diuretics. Alternatively, they are sometimes put on IV diuretics, especially if they are fit candidates for dialysis. and then they're dialyzed to improve kidney function. And that's quite an extreme step, but I have worked in renal and I have seen this happen, so it's a possibility. Okay, sorry. I forgot the remaining questions and it's moved on. The waiting of the patient presenting with edema is always a must. Yes, that's right. That's a very good point to make. Yes. So along with strict fluid input, output, it's always important to weigh the patient. Patients with heart failure or chronic kidney disease often have a actual weight and a target weight that they need to maintain, along with fluid restriction. And so especially if you put patients onto IV diuretics, it's very important to weigh patients, if not on a daily basis, then of course on an alternate day basis, and therefore you will see a drop in weight is assumed to be effective in your treatment, and along with urine output charting. Again, if a patient had a catheter in situ and experiencing pain whilst peeing, is this normal? So I am quite stumped with this question. I don't know if I've got it wrong. So a patient who's got a catheter will not be experiencing pain whilst passing urine, because the urine will be passed through the catheter. I believe you mean that the catheter itself is painful, or that the patient has urge to urinate. So there's a number of things. Yes, it could be normal if, for example, the patient hasn't had a catheter in before, they don't have a long-term catheter, and we've popped one in during the current admission. It's something very foreign for them, and so pain can be normal. Now, there are other signs to look out for that suggest maybe the catheter is not placed correctly, or adjustments of size needs to be done, which is any hematuria, any blood in the urine. If, for example, you're asking someone with a long-term catheter has suddenly developed pain, then it could be that the catheter is infected or blocked, and in which case flushing the catheter, or if you suspect infection, then changing the catheter is the right way forward. Polycystic disease. So polycystic disease is multiple cysts, non-malignant cysts, although it can develop into malignant cysts on the kidneys, is essentially what polycystic kidney disease is. And another good question is, how important is healthy lifestyle in the prevention and management of AKI? So stress can lead to things like hypertension, which can, of course, affect the kidneys. Eating healthily and having a balanced lifestyle, that's always important, not just for kidney health, but also generally for your overall health. But definitely in terms of how much waste material or toxic material is needing to be cleaned by the kidney is very much dependent on what you put into the body as well. So always having a balanced lifestyle, balanced diet is important, although not necessarily a plant-based diet. I think you can have a balanced diet whilst still having meat. I personally am a vegetarian, so I can't really vouch for how that is. And how would you manage a heart failure patient with fluid overload who's already on furosemide that developed AKI, since it has been established that diuretics classed as nephrotoxins can cause AKI? And that's my personal nightmare. And a patient who often comes in when you have very few senior staff around. So realistically, I would first assess how fluid overloaded the patient is. And that might sound bizarre. So if you see a patient who's got fluid overload and pitting edema up to their knees, but you ask them and that's their baseline, that's their best that their legs have ever been in, then I would actually stop the furosemide. However, if the patient is significantly fluid overloaded and they report that they've never been as fluid overloaded as they are at the moment, i.e. their pitting edema has reached further up their legs, up to their sacrum or even their chest, then I would still keep them on the furosemide and think about an alternative in terms of if there's any other nephrotoxins that can be first withheld, with the diuretic being withheld as the last resort. So yes, it's a very tricky situation. Often it's this a senior decision as to exactly which pathway they want to take with the patient. Your job, especially if you are an F2 or a middle grade with no reg on for overnight, is to do harm first of all. So put in management as minimal as possible until a consultant or a registrar is able to fully evaluate them. Often the case is that patients with this presentation may have come in previously, and so you look at management plans that they've had in the past as well, so that all helps. And another question was, how does cardiomyopathy affect the kidneys? So any cardiomyopathy that means poor cardiac function and cardiac output also means poor perfusion of the kidneys. So often the cases with cardiomyopathy, it's not exactly an AKI that you would see in patients. It would often be CKD. But, if there's been an acute development in their cardiomyopathy, then of course you would see certain drastic changes in their kidney functions as well. And I think I've answered about the heart failure question before this, and someone else kindly asked about blood alcohol. So fortified drinks within 2 hours can raise a person's blood pressure to dangerous levels and cause drop in kidney function. Okay, thank you so much. I think that's actually helped me answer a previous question. And yes, is smoking affect kidney and cause AKI? Smoking does affect kidney, but often it will not cause an AKI, but cause a more slower effect on and deterioration in kidney function. So more of a CKD picture with smoking. And if treating a patient with gentamicin, which you mentioned can be quite harsh on the kidneys, which alternative would you consider if you had to stop the gentamicin? So my personal favorite, and the one that the current trust I work at, is aztreonam. It has pretty much very similar cover to gentamicin. And so I would use 2 gram aztreonam 3 times a day. If their creatinine's raised, but their eGFR is still above 30. If it's below 30, then I would do a loading dose of 2 grams of aztreonam and then have 1 gram 3 times a day and titrate as needed. Okay, so one last question, I'm guessing. How would you manage, sorry, I think that's the same question. Sorry, that was the last question. I must have asked the same question twice.
No worries. Great. Thank you so much, Dr. Ganeshamoorthy. That was really interesting, and we really appreciate you taking the time to answer questions for us. Yeah, great. So Just a quick plug for one of our sponsors. So we want to tell you guys a little bit about Lecturio. This is a really cool website and I don't know, app, I guess, that you can use. You can access a variety of high yield medical video lectures. You can take closer look at the human body with scientifically accurate 3D anatomy models. You can test your knowledge and assess your learning progress by answering interactive quiz questions. You can prepare for exams using the most advanced question bank available to you, and even better, all of Lecturio's exam style clinical case questions include text and video answer explanations. So when you guys fill out the form, that will have a QR code that gets you the form for the certificate for this symposium, part of that also gets you the 20% discount if you want to check out Lecturio for your future medical studies. It could be a really great tool for you to help you just do better, be a better doctor. So I'm going to leave this next slide up for a minute. This is the QR code where you can give us your feedback. So feel free to scan it, access our feedback form, and receive your participation certificate and Lecturio discount code. We have some more great symposiums coming your way, so continue to check our SME website for more information. And again, we can't thank you enough, Dr. Ganeshamoorthy, for your time today. This was really informative and we really appreciate it.
Thank you. It was very enjoyable to speak
Great.
about a topic that was very important, I think.
Yeah, fantastic. All right, great. Like I said, everyone, we're going to leave the QR code up for just another couple minutes, so you can feel free to scan it. And this video will be uploaded to our YouTube channel, so you'll be able to rewatch anytime you need a refresher on acute kidney injury.